just to give a bit of background to what I do, my name's Nicky Hollowood. I'm based at Harrogate Trust up north, and I'm the lead healthcare scientist for the trust. But I also have a number of other roles, one of them being I am the point of care testing cross site lead. And to those that aren't aware, point of care testing is a branch of pathology, and it basically deals with diagnostic tests that are used outside the core laboratory department. So it could be used on wards and hospitals, it can be used in community hospitals, GP surgeries, it can also be carried by community nurses out in the community. But these are all devices which are either portable or transportable, and they're used by non-laboratory staff, I think is the key term. I'm the lead for point of care testing over at Harrogate. I've worked here for 20 years now and set the department up, and we have got UCAS accreditation and had it since we've had national accreditation one way or another since 2007. We're the first trust in the country to get the UCAS accreditation, and we currently meet the ISO 15189-2022 standards. So I would like to think we've got a little bit of experience behind point of care testing. And then in June this year, I took on a role of being the cross-site lead for my pathology network for point of care testing. So that includes Airedale and Bradford, and bringing those, looking at point of care testing across pathology networks as a whole. And the whole kind of experience has been a big eye-opener for me, because obviously working across different demographics and different patient cohorts is really crucial when thinking about how to evolve and develop services. So without much further ado, I'm going to go through my talk. So when we talk about the 10-year health plan, I'm sure everybody will be familiar with these two screenshots here. The government released Fit for the Future, which was the much anticipated 10-year health plan for England. So what are we going to do with healthcare services going forward? And then very fast off the back of that, the life sciences sector plan was released as well. So there were three main themes that were identified. Again, probably you're sick to death hearing of these, but if you've never heard of them before, the three themes are moving services from hospitals to communities. It's all about digital transformation and prevention over treatment. So when you read the common themes through the documentation, it prioritises prevention, early diagnosis, personalised care, and integration of cutting-edge innovation into clinical pathways. And a lot of this innovation is medtech. Medtech is medical technology, digital improvements. We can be talking about AI in here. We can be talking about smaller portable devices. So it's really impactful for point of care testing services, which is what I manage, because a lot of pathology testing is getting smaller and smaller, more sophisticated, and the functionality is improving considerably, which makes it much easier to move it closer to the patient. The priorities are linked to the work of healthcare scientists. It's frustrating because when you read the plan, it doesn't really name healthcare scientists, and yet it talks about the work that we do throughout it. And it would have been very nice to have actually got a mention in there about why healthcare scientists' involvement is so important. It talks about genomics as well, which is moving more into identifying genes and mutations before the disease actually becomes apparent. Digital diagnostics, so we're talking more again about things like point of care testing, and things like using smartphone technology. Physiological sciences, again, physiological sciences, the testing for that is becoming a lot smaller, a lot more cutting edge. There's AI being introduced into things like echoes, loads of opportunities there to introduce innovation, and data science. So the important thing about all of these changes is really about regulation and governance, and this is what healthcare scientists have got in abundance. And the concern for a lot of people is we are talking about devices, but we do need to talk about healthcare scientists and what they bring to these services. And what we bring is we develop these devices to deliver the services that we need them to deliver. We look at things like safety, governance, using the right test and the right time. We look at how the results are reported, how they're going to be actioned. It's not enough to say we've got med tech, let's go and give it to clinicians. It doesn't work like that. That's a bit like somebody ordering a bathroom and then giving it to somebody in a house and expecting them to fit it themselves. It's a very specialist task, is taking a piece of medical technology and developing that technology, particularly if it's new, and evolving that into a service delivery method. And that is what the healthcare scientists do. We are the bathroom fitters, so to speak, if you want to use an analogy. At the same time, the UK Life Sciences Vision talks about the need to develop this technology, develop methods, develop AI, and to really start thinking and getting ahead of our game in the UK and embracing this sort of technology. And it's talking about working with commercial, and that is crucial, because one of the reasons why the Harrogate point of care testing service has been so successful over the years is because of our commercial partnerships that we've developed. It's very much two-way partnerships. It's about products coming to market, but us actually engaging with those commercial teams and saying, good idea, but it needs to do X, Y, and Z, because that's a governance issue, or to deliver the service we need, it needs to be able to do this instead. So I've worked quite extensively with a lot of commercial companies to develop the functionality of their devices to make them more fit for purpose. And that benefits both of us, because it benefits our department, because we're not flexing the service to fit the product. And I think too many services these days, we think a product is a great idea, and what we do is we build the service around the product, and we need to stop doing that. We need to be working with commercial so that the product is built around the service that we aspire to deliver. So we talked about those three common themes. So what do we mean by these themes? Now, this is actually a government slide that I've put in here, because it's each time, as time evolves, more information becomes available as to what they actually mean. There's a bit more detail to this sort of strategy. So one of the key things is about neighbourhood health services, and they've already identified neighbourhood health centres and where they're going to be. There's one in my region in Airedale, Bradford area that's been approved. And the whole idea is that my interpretation is they're going to try and move outpatients from hospitals into neighbourhood health centres. So we're talking about more specialists than GPs, but we're not talking about services that you need an inpatient admission for. And this is crucial for diagnostics, because diagnostics at this point could really be an innovator for these services. It could really accelerate what sort of level of services are being delivered. You've got to remember, if they're being taken out of secondary care, quite often our healthcare scientists sit in secondary care. So you're taking them away from that diagnostic, away from the healthcare scientists. So what we need to do is we need to follow that workload, and we need to make sure we're part of that. And, you know, digital technology has enabled us to do a lot of interaction with these services remotely. So then talked about redesigning outpatient and diagnostic services. And again, it's thinking about which services we need to keep on site at a secondary care hospital, and which services we can move off site, and being really sort of novel and innovative in how we think about that. I'm a great believer in we need to decide what the demographic need is first. So what are the health inequalities in our area are? So what do our community need in terms of healthcare services? We then build the clinical, and clinical can say, right, we can service these needs with the following, but diagnostic needs to be included in that, because quite often clinical get involved without the diagnostic teams, without the healthcare scientists, and they hit that first hurdle where say, well, we can't do that because we don't have access to this test or to this service. And instead of engaging with those teams and saying, how can we enable access to that? And, you know, brainstorming together. And also there's going to be a lot of focus on redesigning urgent and emergency care. So we've already seen a lot of this happening already this winter. There's a lot of pressure on urgent and emergency care, particularly meeting the 4-hour turnaround targets and trying to push people sort of back to community services. Again, I think my concern is that people just go to ED as standard at the moment. They don't even try and seek care from, you know, the community. There's just a kind of acceptance it's not there, even though it might be there. And so I do believe that this needs to be a push from secondary care into primary care, rather than, you know, primary care just going, we've got these services and expect everybody to come to them. There's got to be a push back from ED into that primary care, but there's got to be something to push them back to, and it's got to be high quality. So again, analog to digital is all about giving people access to results and sharing results between different clinicians and services, and that is really key. Quite often what happens in point of care testing, if the pathology team isn't engaged, is the result will be generated from a device and it's written down on a piece of paper somewhere, or it's put in system 1 record, or a record that's only accessible by one particular clinical team. And what I think is crucial, particularly for point of care testing, is that we put those results from these tests that we do outside the lab with the lab results as well, because it's important they have a whole diagnostic record together. You don't need to be looking for one test result in one place and another test result in another place, and then trying to second guess where all these tests are, where they've been done and where you're going to find them. And when they come to a GP and they're like going, whoa, I don't really know what's going on in this patient, because all they'll do is they'll reorder all those tests again. And it really should be about doing the right test in the right place and making sure the result is reported in one accessible place, and it's accessible to the patient and it's accessible to all the different caregivers. And then moving into sickness to prevention, again, a lot of this is really around keeping people healthy. And we do a lot with, particularly in pathology, around screening and, you know, making sure we pick things up like diabetes and high cholesterol and things like this. There's a lot of projects going on at the moment in primary care. In my region, in West Yorkshire ICB, there's an Innovate project, which is about obesity management. And what's really promising is they came to me and said, we're thinking of doing this, we're thinking of doing HbA1c testing. What do we need to do to make this work? And that, by coming and speaking directly to myself, and the reason they spoke to myself is because I'm very vocal in my area about trying to promote the profession. And I think that's what we've got responsibility about doing as healthcare scientists, is being very vocal about what we do. So if people know what we do and where we are, they will seek us out. Whereas we sit there expecting everybody to come and find us because, you know, some project funding's become available and it's got pathology in it, or well, they'll go to pathology. Quite often they don't. Quite often people go, there's a pot of funding here, it's for primary care, we're going to put the bid in. And they often go to, not all the time, but what I'm seeing a lot of is the seek out advice of healthcare scientists when things go wrong. So things, you know, pilot projects haven't worked out, or there's an issue that's raised and they go, actually, we need to go and speak to somebody about that. And I think it's really important we are there at the start and we educate our, you know, colleagues about the value of what we do. So the plan also identifies what's known as 5 big bets, which is more about using data to deliver impact. So it's about doing more healthcare research and trying to understand the risk factors, particularly in population health. So you might find, for instance, that heart failure rates are increasing in your area from healthcare data, and therefore to do something, being aware of that, you might be able to put some preventative actions in place. AI is mentioned a lot. And I think AI is a bit baffling sometimes, because I personally think we've been using AI for a long time. You know, AI is just a computer's way of interpreting something. And many years ago, I worked at Leeds 20 years ago. And one of the things we had to do was identify peaks in a chromatogram. And they brought in this technology so that the program would identify the peaks for you. And that is AI. It's a computer doing it for you. Well, that was 20 years ago. So I don't think we should be frightened of the term AI, because I think, unfortunately, AI seems to be associated with people faking things and fraud, and that's quite worrying. But AI is basically doing what we've always done, which is using technology to do the components of the job that we don't necessarily need to do, that may be quite repetitive. However, we do need healthcare scientists to set AI up, because there's that element of verification that has to be done. As we know ourselves, if you use Copilot and get them to take minutes, on the whole, they're usually really good, but sometimes you do get some real random statements in this. So that's really what we need to do, is we need to ensure that that AI technology is governed, it's robust, and it's used appropriately. And we are the people to do that, because we know what the right results are and what this should look like. Again, robotics to support precision. I mean, there could be robotics in terms of somebody demonstrated a robo-dog who took blood samples from one part of the hospital to another part of the hospital. We've seen drone technology being implemented in a London hospital to transport blood products across the city to get away from all the traffic. You know, so it seems a little bit sort of far-fetched, but it's not that far-fetched anymore. Then we've got wearables. This has become standard, Fitbits for people, but we're seeing more things like patients using like Libras, which monitor their blood glucose level. They do it for general health reasons. They do it because they've got diabetes. And we're going to see more and more of people having wearables. But again, it's about understanding, you know, supporting individuals to use these appropriately, and understanding when test results might actually not be right, and when to trust them, when to then question them. And again, genomics is there's a heavy component on genomics. So what can we do? So our role, I feel, is around leadership. If nobody's going to come and ask us for leadership, we really have to grab that by the reins and say, you need us to lead this element of this 10-year plan. A big part of the leadership is educating people about governance, clinical governance, technical governance, why safety, why it's important to get that right test result, and what we do to ensure that that test result is correct. They need us to develop these pieces of kit. These pieces of kit that you see, they may present themselves and be marketed as final products, but they really are not. They're just a piece of kit. We need to develop these into services, and that is the key difference, is how do we actually take technology that's available out there and develop it into service provision, and to deliver the outcomes that we need to deliver. Research, some of this technology is there, but it's not good enough. So how can we work with research teams to generate enough data to bring that technology on faster, to get it to market faster? And also, we mentioned earlier on about AI application, where it's crucial that our healthcare scientists are involved in the use of AI, because we're the people responsible for ultimately making sure that the AI is accurate, and we verify and validate that appropriately. So we've got a real opportunity here to lead the redesign of clinical services, propose effective ways of working, and develop medtech into service use as well. So just very quickly, going to give you a few service examples that we've done here at Harrogate. So not this winter, last winter, we implemented a rapid lateral flow testing service into our ED department. This was connected, as you can see here, it's effectively a mobile phone on a stand with some software on it. We developed a clinical decision pathway, which was based around infection management, not diagnosis. And what we did is everybody who came into ED had a swab and had the 4 tests, flu A, flu B, RSV and COVID tested. It gave them results in 10 minutes. It was timed, it takes a photograph. It also interprets the results. You can see here, it's a very faint line. So it picks up the positive results that some people wouldn't actually pick up as well. The readers are electronically connected to the patient's records, and it's also connected to an alert system. So every positive sends a real-time alert to our infection prevention team. So every time we get a positive, our infection prevention team get an email saying we've got positive in ED, and straight away it enforces and enables multidisciplinary working. So our infection prevention team goes straight down there. They know what's going on with infections across the hospital. They can advise about the best method for isolating and patient placement, bed placement, etc. So what has the benefit of this been? First of all, PCR is £50 for Kefid and £110 for BioFire. This test, including all the technology, it roughly retails about £10 a test. So immediately straight away, you can see it's a lot cheaper. Secondly, the results are a lot faster, and that's particularly crucial for ED, because instead of floundering, having somebody who's presenting with general respiratory viral symptoms, but you don't know if they're positive for anything, what do you do with them in ED while you're waiting for a PCR result? You are essentially, you've got an open ward down there. It's a breeding ground for viruses, particularly for staff and other patients. You could have someone coming in with a heart attack and they're being exposed to flu A straight away just because of the environment they are in. So what this has led to is we've been able to isolate people faster. Our staff sickness is lower than the national average. So it was 3.25 average last winter, which was unbelievable for staff sickness in ED. We are one of the trusts that are just about hitting the 70 to 80% for our discharge in ED, because straight away our clinicians are like, right, COVID, I'm happy, you can go home. It's enabling faster bed management. They're able to work with the infection prevention team going, right, this patient needs to go to a ward. They've got flu, they've got this, they've got that, they need to be admitted. We ended up running out the side room because there's so much flu this winter. So we could create a flu A bay. So we had our flu A's in one bay and our RSVs in another. And again, just because we had these results, if you know what I mean. So instead of everybody sitting there together, we know exactly who's got what. So we're able to prioritise people faster. So they absolutely love this down in ED. And I have done a presentation on this upwards of 20 times to NHS England, to infection prevention nurses. I've been challenged on every level, but it's not as accurate as PCR. I'm like, it doesn't need to be. It picks up the positive infections. It's not about diagnosis, it's about infection management in ED. So now we are taking this technology and we're taking it out with our hospital at home team to our failed patients. It's got a real opportunity to implement this in care homes. So, you know, prevent those outbreaks that we saw. What is brilliant about this technology is if you get a new lateral flow test, let's say a new virus comes out, you can use this technology and the connectivity and just do it for another test. So it's scalable, it's adaptable. We've compared it to the PCR. The clinical decision pathway is robust. And this has been led by the pathology team. And the people who benefited have been the ED team. They've been 100% involved. Every team has been involved. But the driving force for this technology and for this service has been pathology. And we were one of the finalists for the Medipex Awards this year. Unfortunately, we didn't win. Wonderful lady from York won with fantastic innovation. But, you know, this has really benefited people up and down the country. And even like our local friends and family, a colleague of mine, her son had flu A, and he got admitted to Harrogate and picked up immediately and seen to immediately. So it's so robust. So just again, technology, but to use that technology without the clinical decision pathway, without the digital setup, without the scientific governance, wouldn't give us those outcomes that I talked about. It would just be an additional test that's used, and and it just costs money. I'm very aware of time, so I'm going to speed quickly through this. This is the research project that I'm doing because I'm one of the innovation fellows for the healthcare science. So it's paused this year, but I was one of the cohort last year. This piece of kit gives a full blood count result in 5 minutes using 1/10 of the sample that you use for the laboratory. It's particularly important in neonates. So neonates, their blood samples clot very quickly. Quite often, up to 30% of neonatal samples are clotted by the time that they reach the laboratory. So neonates are often very sick, particularly in paediatric intensive care units, and got a low blood volume, so you really don't want to be drawing too much blood from these. Not just that, the process of drawing blood induces physiological changes in neonates as well. So what this piece of kit does is it uses 1/10 of the volume of sample. It gives the results in 5 minutes before the sample touch to clot, leading to reduction in repeat draws, faster results, and improved clinical outcomes. However, this piece of kit is not CE marked for above 2 months. So what I've been doing is working with the company, and I've been working with the National Institute of Health Research to get the data needed to get it approved to put into service use for the less than 2 months. It's a very, very complex process, but I think this piece of kit is brilliant. I think it's a real game changer for neonatal medicine, and it's one of these things that I'm prepared to stick my neck out for and say, actually, I'm going to put a lot of time in to try and get this kit into service use. I mean, the staff absolutely love it, but we can't use it in routine service use yet because we've got to validate it against laboratory samples. But there are a number of research opportunities that healthcare scientists can do if we see medtech available, but it's not quite market ready. People can do fellowships, they can do PhDs and things like that. Those are available. The last one I mentioned was hospital at home. We've got a hospital at home team who go out to people on the frailty care pathway. So they basically take portable kit with them. This is about to go live here. It's live in lots of other places in the country. This is not new to us at all. And what it means is when the medics are in the patient's home that get those results, they can adjust the medication there and then, instead of having to then follow up, take a lab sample, wait for the lab result to come back, and then follow up with a phone call. And that can be particularly challenging because a lot of these patients are elderly, struggle to hear on the phone, and it's quite frightening if a medic calls up and says, right, you need to change your medication. Instead of taking this, you need to take that. If they're with you and they say, right, you've got 2 blue pills, you just need one of these blue pills now, they can assure themselves the patient has understood and is following instructions and what have you, whereas at the moment they're having to assume that remotely. And then just finally, where do the opportunities lie? Well, the opportunities for us are clinical diagnostic centres. We're already in these, but there's so much opportunity for further growth in these. Neighbourhood health centres, nursing homes, urgent and emergency care, including ambulance services as well. There's so many things we can do with medical technology to develop it and evolve this into service provision. And then just finally, this is the NHS Clinical Entrepreneur Programme, which is similar to the one that I'm doing my research project with. And this is open every year, and it's for people who work in the NHS who have got a great idea for innovation, but want to work with people who understand about bringing products to market, to services. So you get that full support with that full team, but there's also like an associated bursary and things like that. So if you are interested in doing sort of research / innovation, this is a really, really good programme that is available. And that's it. I think come to 1 minute over, so I think I've stuck to time.